spinal cord dissection. Many pathologists do not examine it routinely, but this should ideally be examined always. Methods of removal: anterior approach, posterior approach, removal of the entire vertebral column and extracting the spinal cord later following fixation. This technique saves the time during the postmortem but makes reconstitution of the body much more difficult. Removal usually removed separated from the brain but can be removed in continue with the brain from from a posterior approach if necessary. Generally, in tumor of brainstem, anterior approach advantages body need not be turned over MSC procedure if evisceration has already taken place, allowing the narrow root and dorsal ganglia to be dissected. Disadvantages are more difficult. Posterior approach advantages quick and easier, but should be performed before the rest of the postmortem to avoid mess. Allows for removal with less tension in the coda. Allows the subcutaneous tissue and brain to be removed in continuity. Disadvantage: does not allow easy examination of the nerve root or dorsal ganglia. When body is returned to relatives, the sheet may become blood soaked through oozing of blood from the posterior incision. To reduce this oozing, it is advisable to put a plastic sheet inside before sewing up the incision. Technique: keep a body in prone position. Make an incision in the midline from the occiput to the coccyx. Use forceps and scalpel to dissect as much soft tissue as possible from the bone. If necessary, more horizontal cut at the lower end of the incision. This allows the subcutaneous tissue to be folded back in a flap so as to leave the vertebral column exposed without hands or retracts to keep the skin incision apart. A rachotomy saw, especially in the high-risk cases, and or oscillating saw is used to divide the exposed lamina. The cut should be directed forward and slightly inward and should be placed to about 2 cm from the midline on either side. Unlike the anterior approach, the necessarily angle of cut does not change along the entire length of the vertebral column. As soon as the saw gives it in, it should be withdrawn to avoid damaging the codas. With the anterior approach, it is preferable to do a short length of on either side. This allows the vertebral column to be exposed and thus ensures that the saw is in the correct plane and position. The cut should be started inferiorly at the sacrum, where a horizontal cut should also be made to join the two vertebral cut together. When at the upper cervical region, a further horizontal cut should be made. The vertebral column can now be lifted free and dura exposed. If the saw cuts have not been exactly in the correct plane, it may be necessary to chip away bone with the forceps to expose the cord and sufficiently allow its removal. Once the cord is exposed, it is best to mark certain key nerve root with a string before removal, and to aid future examination as a nerve root level are extremely tricky to identify in the separated spinal cord. Before the cord can be removed, it is necessary to free the dura from about the foramen magnum in the same as way for the anterior approach. This is possible only from above and therefore can be undertaken only after the brain has been removed. Unless the brain and spinal cord have been removed in continuity, using toothed forceps, the durameter of the upper cervical cord can be delicately grasped and a scalpel used to free the upper 2 to 3 cm. The cord can now be removed with the dura intact using anterior forceps. The lumbar region should be gently gripped and the dura and nerve root transected with a scalpel distal to the caudicum. The caudal end of the cord can then be gently lifted and adhesion being separated with the scalpel and procedure continued rostally. Avoid torsion during the procedure by keeping the cord as straight as possible. It may be wrapped in a length of cotton wool or similarly soft material whilst lifting it from the vertebral column to decreases the risk of damage. The spinal cord then can be examined immediately or fixed for later examination. Examine empty canal for disc protrusion, dislocation, fracture, tumor, and vertebral collapse. Removal of spinal cord in continuity with the brain is necessarily unknown. Posterior fossa or upper cervical spinal lesion. Midline lesion is extended to the vertex of the skull to the level of the coronary scalpel incision. The scalp is reflected laterally, and a coronal skull incision from the lateral edge of the foramen magnum around the cranium to the opposite edge of the foramen magnum is made. Incised cranium is removed. Intact brain with the spinal cord can be removed easily. It feels a bit different because brain is removed from behind rather than the front. Examination of spinal cord. Orient the cord in anatomical position. Note that a single artery is present on the anterior surface and a complex arterial plexus on the posterior. Open dura anteriorly along its length using small scissors. Look for presence of crushing, degeneration, hemorrhage, infarction, inflammation, suppuration, and a tumor. Examine external surface of the spinal cord. Slice the cord at approximately 5 mm interval and lay out in the same orientation as the brainstem. The slice should be made in between rather than at the level of nerve to avoid their damage. Take blocks for histology. Clear noting the sites of origin. Mark one surface of the block by inking or notching to allow orientation of the final slide. Fixation. For detailed examination of the cord can be fixed in formalin in 4 weeks. Ideally, it should be suspended in a tall pot to prevent curling. However, if the dura is intact, it is acceptable to fix in a curled position. Thank you.